what does that mean in terms of what we need to be doing with them? Okay, so that's not too big. So I'm going to give you a model that there's a reference to in this bibliography. This Blaskin and Kinneberg book is a really excellent, excellent book. It was published in 2010 called Treating Traumatic Stress in Children and Adolescents. And I'm going to be talking a lot from the material in that book, a lot of what I'm going to present. But I am thrilled to tell you, those of you who are possibly in this audience and actually doing treatment, which there may not be a whole lot of people, that this first flyer is about training in this. And let me tell you, it's very hard to get this training. So I'm thrilled that St. Peter's is actually sponsoring a 2-day training on this. And I'm looking at Lucy because I don't know if there's any other treatment people here, but this is something that really people who are doing treatment need to learn. But the wonderful thing about this model is that while it talks about what therapists need to do, it really talks about the fact that therapy, the way we think about therapy, is not going to address this problem. All right? When we think about therapy, you know, you have a therapist. Where does it usually take place? In somebody's office. How much does the therapist see the kid? Once a week. For how long? An hour. 45 minutes. Okay. The notion is that this kid is living with these problems. And the response to the way the kid is experiencing the world and acting has to be 24/7. And once a week just has no impact if 24/7 is not also present. So this book talks a lot about what other people besides the therapist, but including the therapist, need to be doing with the kids. Now, who are these other people? Who are we talking about?
Foster parents.
Certainly we're talking about foster parents. Who else are we talking about?
Caseworkers.
Caseworkers, absolutely. Who else are we talking about?
So you're saying this training is not just for therapists?
Well, I have a feeling that the training is going to be focused on therapeutic stuff. So I don't want to necessarily say anybody and everybody should go in. But I am, you know, you could call and find out. But I have a hunch it's really geared toward therapists. Because I think the notion is that if you get therapists trained, they will do the work with foster parents and other people to try to get them on board. And there's a lot in that book that tells therapists what kinds of things they should be working with foster parents about, for example. But the point is that it's got to be done by everybody involved with the kid. So we said foster parents, we said caseworkers. Who's another major group?
School teachers.
School teachers, right? The teachers are with kids at least 5 hours a day, 5 days a week. And the kids are doing all this in the school, right? If no one in the school is responding to them in an appropriate manner, anything that a therapist does 1 hour a week is meaningless. All right? So we're talking about everyone around that kid. It might also include mentors. It might include clergy. It might include the coach of the softball team. It might include the lawyer who represents the kid and has to talk to the kid about plans for the future. It might include the judge who might bring the adolescent in to see what the adolescent thinks and is trying to somehow engage with this adolescent. So it really includes everyone. And there's a slide I should have had next saying that. So this model is called the ARC model, and ARC stands for attachment. The R is really regulation, self-regulation, and the C is confidence, and we're going to talk about each of these. And they're arguing in this book, and really a lot of people in the field these days are making this argument, that if you have these kids with this kind of history, you have to teach them how to cope with life before you can get back into the trauma history. Now, let me go back to this acute trauma difference. There's a whole very well respected, and I respected as well, treatment model, cognitive behavioral trauma focused treatment that targets kids really who've had acute traumas. It really is not designed for kids with the kind of traumatic histories we're discussing. So kids who have, even sexual abuse or assault, if that's the only thing that's happened, but they've lived in a fairly stable home, and they have supportive parents, and nothing else really bad has happened to them, those kids, you can do this trauma-focused cognitive behavioral therapy, which very quickly takes you into talking about the traumatic event. But for kids who have no means of coping with heightened levels of emotion, you get them to start talking about all the bad things that happened to them, they leave more distressed than they came in, and they go and they do things as soon as they leave the office or wherever. So dealing with these kids is teaching them how to relate to the world in a healthier way before you start talking about trauma. All right, and so there is this discussion in the book about what they call trauma experience integration, which I'm not going to talk about at all today, because that really comes after there's been some development in those other areas. There's been changes in those other areas. You don't want to start getting into the trauma experience until there are changes in these other areas, which I'm going to talk about. Now, before I read this book, I was aware of this article by a man by the name of Beth, who used the term trauma-informed care. That was the first place that I had really seen this spelled out. And the point he makes is that care refers to the preconditions or co-conditions for therapy. That simply referring a kid to a good therapist is not ever sufficient. And that there are certain things that have to happen alongside of therapy, sometimes even before therapy. And he says the three main components of that are what he calls safety, connections, and emotion and impulse management. Now, I think these three components are very related to the three components that the Blaustein and Kinneberg model talk about, and I just created a slide to just show you that I think, how I think that, well, this is what I was talking about before, a little out of order, but these are all the people who need to provide trauma-informed care. Now, these two models, I think the attachment that's discussed in the ARC model is related to safety, that the self-regulation that's discussed in the ARC model is related to emotion and impulse management, and that confidence, as discussed in the ARC model, which we're going to get to, is related to what Beth calls connections. So I'm going to kind of try to go through each of these categories, explain a little bit about them, and the kinds of things that these people are saying has to happen in our work with these kids, not just in therapy, that will help them move on in their lives. So, safety. Let me talk for a minute about safety, and I kind of alluded to this already. Safety is not just physical. It's also psychological. If you think you're about to be thrown out of a foster home, if you think people hate you, if you think that there's a whole negative emotional tone going on, even if it's not true, if you think that that's happening, you don't feel safe, right? And you cannot heal and you cannot trust if you don't feel safe. So it is very important for those of us who are working with kids to be constant, in whatever the format, to be constantly checking in with them about a sense of safety. Just for example, if the DCPP worker comes once a month and sees the kid, a question that could be asked of the kid is, have you been feeling safe? Is there anything that makes you feel not safe? Just the asking of that question is significant. The kid may or may not answer, but the asking of the question tells the kid that this is something that you're concerned about. Now, they may tell you something that seems ridiculous. They may tell you something that makes them feel not safe, that you think is not legitimate, is not realistic. Why? That's not a sign of lack of safety. But the issue is how we deal with it. So just as an example, supposing you say to a kid, is there anything that makes you feel not safe? And the kid says, yeah, every time she laughs at something I say, I don't feel safe. Well, people laugh at all kinds of things. I'm now involved with the raising of my twin grandchildren, who are 2. And I have twin daughters. These are the children of one of the daughters, who are 35. And my twin daughters, I remember vividly you know, they say cute things when they're 2, and I see it happening now again. That's why I'm telling you this, and we were just discussing it tonight at dinner. You start laughing because they say something cute. And my daughters, I remember this, used to say, no ha-ha. No ha-ha. Now, you know, you're not intending to hurt their feelings, right? But their feelings get hurt. They get it at some point that you're laughing at them. Now, I mean, I think this passed, and we kind of got past it. But I'm just giving you that as an example. If you say to a kid, is there anything that makes you feel not safe? And the kid says, well, when she laughs at something I say, the foster mother, I feel like, you know, she's going to throw me out of here one of these days. What do you think the attuned response to that could be? I mean, what would you do with that?
I mean, to encourage the child to somehow add reality tests on whatever level.
Okay. So that's certainly one very good suggestion. Any other thoughts?
Explore.
Yeah, I mean, you'd want to explore it a little bit. You know, what is the kid worried is going to happen? All right. Maybe the kid doesn't say I'm going to be thrown out, but the last time somebody laughed at me, the next thing I knew I was out on my rear end. Okay. Now, it is important to get to the reality of it, but let me tell you, it's equally as important for that to be, and it may be that the caseworker has to discuss it with the foster parent, because it may be that the foster parent is going to have to inhibit that a little bit. These are damaged children. So even if there's not a good basis in reality, you see, it may be very hard for that kid to say, oh, well, she's really not going to do it because she says she's not going to do it, when my whole life has been one where I can't trust anybody. All right? So now, you see, that's the challenge here, is to really get the adults in the kid's environment to start shifting what they do to meet the needs of the kid, even though it doesn't necessarily make logical sense. Does that make sense to people?
It's about validating. About validating.
Well, it's about protecting. It's about providing safety. I mean, see, it's validating the kid's concern without validating the reality of it. Right? It makes you feel scared when somebody laughs at something that you do or say. So we want to try not to do that. It doesn't necessarily mean that, you know, what you think it means. Maybe it does, maybe it doesn't. But we're going to try to stop that because it's making you scared every time it happens. That's the issue. All right, so it does involve a willingness on the part of everybody around the kid. So that's the teacher, the foster parent, whoever it is, to make adjustments. Because we're dealing with traumatized kids. That's what it means to provide trauma-informed care. We're dealing with kids who have distortions and fears.